And as pharmacy technicians, there's one thing that I do know for sure is that we always have to be on our toes. And so we are on our toes first thing this morning because we have a change in our program. We have the same topic, however, we have a different presenter. Dr. Paul Dobish was scheduled to present, but he got pulled away suddenly and unexpectedly. But being the great guy he is, he found a wonderful individual to give the presentation for him. So I would like to introduce Dr. Drew Prescott to give the presentation on measurement of vital signs.
All right, thank you. I don't get a round of applause from my students when I'm teaching, so it's kind of nice to get that to start the day off. So, well, as Judy mentioned, I'm stepping in here, but Dr. Dobish and I have kind of worked together. He teaches the vital signs to our first year pharmacy students during their second semester, and I've been helping him out with that course a little bit, so hopefully I'll be able to teach this in a way that makes sense to you, but welcome any questions that you have along the way, kind of as we go through this. Vital signs is really important, right? It's kind of our baseline of understanding where a patient is at with their care. And so from a vital sign perspective, as pharmacists, as pharmacy technicians, and as the scope of the pharmacist and the pharmacy technician expand, it's important to understand what these mean and then hopefully be able to act on it, right? As our scope does begin to expand, I think that technicians can play a really pivotal role in being able to measure vital signs and communicate with the pharmacist and the healthcare team to make decisions and help patients along with their care. So today we'll be covering blood pressure checks, we'll be covering pulse checks, we'll be looking at how to monitor and check a temperature, and also looking at pulse oximetry. So we'll review those today. Again, if you have any questions along the way, feel free to raise your hand. You can stop me at any time. Let's see if I can get my clicker here. There we go. Okay, so as I mentioned, vital signs. On the left hand of your screen here, we have kind of 4 different categories as we think of for our classic vital signs: pulse, respirations, blood pressure, and temperature. And then there's another category that we consider in the realm of vital signs is vital statistics. So that would be your age category, height, weight, and then whether you're a current smoker. So my clinic site is over at Midtown Health Center. It's a primary care clinic. Whenever we bring a patient in, and maybe if you've been to your primary care doctor in the past couple of years, you've had some of these vital signs or vital statistics recorded. We try to make sure that everybody that comes through our door in the clinic has that recorded. And from a pharmacist perspective in the community, I think that these are all things that can be done and can be recorded in the community setting. And so these are kind of our categories as far as how we think of vitals in general. From a pulse perspective, so how do we check pulse? I'll have a little bit of demonstration just on myself, but as far as how we actually do a pulse is we're palpating our arteries. The ideal position to check your pulse is to check your radial artery, which is kind of in this notch right outside of your thumb. The reason that that's the best way to check your pulse is it's usually the artery that's the closest to the surface of your skin. And so you're going to be able to get the pulse a little bit easier that way. If you are catching your pulse on other areas of your wrist, it is still an accurate pulse. It's just a little bit harder to consistently get to that area. And so trying to find that notch in between your thumb and kind of your lower wrist right here is going to help you find your pulse. Now, in addition to being able to do this manually, we have several different digital technologies available, right, that are able to help us with this nowadays too. So if any of you are wearing an Apple Watch or any sort of smartwatch, that's a pretty accurate way to check a pulse as well. And there's other digital technologies that can help us do that. In fact, our blood pressure monitors in clinic actually will check their pulse while checking their blood pressure as well. And so it's kind of getting the patients 2 of their vital signs at once. The pulse, as far as from a clinical perspective, is measuring or monitoring our cardiac function. And so cardiac function, essentially meaning how well our heart is working. And so the pulse can tell us a lot of different things. Usually for a normal patient, it's between 60 and 90 beats per minute. For a patient who we deem as tachycardic or having a higher pulse, it's higher than 100 beats per minute. And then bradycardia, or having a lower pulse, is less than 60 beats per minute. Now, this can vary, and normal can vary for different people. So everybody's baseline for their pulse is a little bit different, and it can also depend on what their life has been like in the past, right? So if you measure somebody's pulse and they've been a long distance runner for 20 plus years, you might notice that their baseline pulse is between 40 and 50, and that's normal for them, and it's a healthy place to be. It might be classically bradycardic, but it's an okay thing for them. So you also have to kind of take in what their baseline pulse is before you start to make any brash decisions as to what you might need to do from a triage perspective or who you might need to get involved. In addition, from a tachycardic or bradycardic perspective, let's say their normal baseline is between 60 and 90 beats per minute. If you're more tachycardic, that could be a sign of possibly having a fever or some sort of infection going on. They might be at more of a higher anxiety state, or having some difficulties with their breathing. If they're having difficulty breathing, sometimes the heart tries to compensate for that and can lead to more of a tachycardic state. From a bradycardia perspective, less than 60 beats per minute. That can also mean a lot of different things. But for some patients, it could mean that they have an infection and things are getting worse and their heart isn't able to respond well. Maybe they have a history of heart disease and they're bradycardic and experiencing difficulty as far as their heart functioning in general. So there's lots of different things there as far as how we would consider and then triage for a normal pulse or a bradycardic or tachycardic pulse. So that's our pulse section. Any questions on pulse in general? Relatively straightforward. You all have probably done that at one point in life, right? The second piece is respirations. So oftentimes checking respirations can be done in conjunction with checking a patient's pulse. So oftentimes what we teach our students to do is, as they're monitoring or checking a patient's pulse, to rest their hand on the patient's shoulder after you've checked their pulse and to monitor their respirations. The one thing you don't want to do, especially when you're manually checking respirations, is to tell the patient that you're checking their respirations, because they're going to start to monitor their breathing and start to think about it, and so that could lead to a false reading. So just laying your hand on their shoulders while you're checking their pulse, even if you're not trying to check their pulse at the time, you can try and check their rise and fall of their shoulders, or you can take a look at their stomach as well, and oftentimes you can see their stomach expanding and contracting, and that can give you an idea of how their respirations are monitored. Normally what we encourage our students to do is, when they're checking the pulse, is to check the pulse for at least 30 seconds to get an accurate reading, and then multiply that number by 2. You can check it the full 60 seconds as well if you want. For respirations, since you notice that the number of respirations is less than the beats per minute for a pulse, you want to at least go for 30 seconds on respirations to really give yourself an accurate number, because if you go for only 15 seconds, it can lead to some discrepancies as to how that number gets multiplied times 4 and lead to some inaccuracies there. So as you can see, we have some thresholds as well from a normal tachypnea and bradypnea perspective. So normal is usually between 12 and 18 respirations per minute. Tachypnea, you might see that again with maybe a more anxious individual, or maybe somebody who has a history of lung disease like asthma or COPD. Bradypnea, again, it's difficult to determine what's actually causing that, but it could be the secondary to some sort of infectious process or something else going on with the patient. Maybe they've gone into some sort of shock state where they're having a difficulty breathing and their respirations are less. Again, everybody has a different baseline from a patient perspective. So if you have that runner who's been running for long distances for 20 years on end, their respirations might be less than 12 per minute. Somebody maybe who doesn't have the cardiovascular endurance or fitness as a normal person might have more of a tachypnea state. Any questions on respirations? Those are usually two of the easier ones to review. The next one we'll check on is blood pressure. Has anybody checked blood pressure in the pharmacy before for a patient or helped monitor one? Okay, great, excellent. So blood pressure monitoring, I think, is something that our community pharmacists are very well equipped to do, and our community pharmacy technicians are very well prepared to do. And one of the reasons for that is we have the measurement tools available, and we hopefully can then make adjustments or make recommendations based off of those measurements. So when we think about a blood pressure cuff, all of you have probably had your blood pressure checked at one point in time. It should go over our brachial artery, so the upper arm, for our right or left arm. For an adult and a child, the width and the length are going to be an important piece of the puzzle to get an accurate measure of the patient's blood pressure. So one thing you want to make sure of is that the width of the cuff is greater than 40% of the patient's arm. So when we think about the actual width of the blood pressure cuff, it should be greater than 40%. And then the length of the blood pressure cuff should be greater than 80% of the patient's arm. And that level is appropriate to make sure that you're getting an accurate reading. You're able to actually kind of cut off the patient's radial pulse so that you can then catch the cross-cough sounds that we'll talk about here in a few slides. If you have too tight of cuff, you're at risk of having a falsely elevated blood pressure. If you have too loose of a cuff, you're at risk of having an inaccurate blood pressure, usually on the lower end. So too large or too loose is going to lead to some inaccuracies, usually on the lower end blood pressure wise. If it's too small of a cuff, it's going to lead to an elevated blood pressure. So the blood pressure cuff should be placed across the arm. There's usually a little notification arrow where you're going to line up that arrow with the patient's brachial artery, which runs usually right across the crease of the arm here. As you line that up, then you're able to start inflating the cuff and checking the patient's blood pressure. But before any of that fully happens, you really want to be able to counsel the patient and make sure that the blood pressure number that you're getting is going to be accurate and an accurate representation of the patient's blood pressure. So what do I mean by that? Well, a normal blood pressure as we check it, and the standard way to do it is to have the patient sitting at rest for at least 5 minutes. Now, I don't know if any of you have been to your primary care physicians or a clinic in the last few years, but if you have, most of the time that's not happening where you're able to sit for 5 minutes and get a blood pressure checked, right? So oftentimes we need to recheck the blood pressure if it is elevated, because it could be falsely elevated if they've checked it right as you've walked in. Maybe you are anxious, or maybe you've been rushing to the clinic because you're 5 minutes late for the appointment, and all those things can elevate your blood pressure, right? And so one of the things that we encourage our rooming staff to do in clinic, and one of the things, especially in the community pharmacy, you might have a patient walking around a grocery store, you might have them coming in and anxious about the medication that they're going to be getting. Having them sit for about 5 minutes before you actually check their blood pressure is going to help you get the most accurate blood pressure for them and not give you something that's falsely elevated. The other pieces that you want to check on is whether the patient has had any caffeine in the past 30 minutes, or if they've smoked in the past 30 minutes, or if they've exercised in the past couple hours. Sometimes that can also falsely elevate their blood pressure and is a good thing to double check for them. In addition to that, the patient should be sitting down, and they should have their feet flat on the floor. And when you're checking their blood pressure, ideally they're going to have their arm out at about heart level and resting on a surface. If they don't have a surface to rest it on, you can support the patient's arm while you're checking their blood pressure, but it should be at about heart level, okay? So when you're checking a patient's normal blood pressure, or when you're trying to make a formal diagnosis of high blood pressure, the patient should be in a sitting position. Sometimes we'll also check the patient when they're standing or when they're lying down, and often that's when we're assessing for what we call orthostatic hypotension, which is a fancy way of saying a patient's blood pressure when they stand up is falsely, or not falsely low, but is actually dropping lower than we'd like it to be, which could lead to dizziness, could lead to a risk of falls, and we want to try and avoid that. Oftentimes patients who are on blood pressure medications might be at risk for having orthostatic hypotension if they have noted that they're feeling dizzy upon standing up, or they've fallen when they've stood up too quickly, or they feel like they're wobbly or imbalanced. It might be appropriate to check their blood pressure while they're standing, or check their blood pressure while they're lying and determine the differences between the two. I won't go into kind of the characteristics behind that as far as what numbers you need to specifically look for. I think that goes a little bit beyond for what we need to cover today. But that's why you might check for standing or lying blood pressures. You want to make sure to use the correct cuff size, as I mentioned, the greater than 80% and greater than 40% thresholds earlier. And then the placement of the blood pressure cuff should be going over that brachial artery. That's usually the most accurate way to do it. We'll talk about some different special populations where you might need to use the forearm. Any questions on kind of the positioning and characteristics that goes behind checking blood pressure? Okay. So the actual mechanism, or the way that we do this when checking a patient's blood pressure manually, is we first check the patient's palpable systolic blood pressure. So what does that mean? It means that instead of listening for the patient's blood pressure initially, we're going to check for the time when the patient's radial pulse gets cut off from their, when you're checking it, when you're inflating the blood pressure cuff. And the reason that we do this is to avoid being misled by the oscillatory gap. And I'll talk about the oscillatory gap in a couple slides here. But this gives us the point at which we should inflate the cuff initially. And it helps us to prevent from overinflating. So let's say a patient's normal blood pressure is usually around 120 over 80. If I were to inflate a blood pressure cuff up to 180 or 200, that might be overinflating the cuff and actually give them a falsely elevated blood pressure because I've caused too much constriction. So palpable systolic blood pressure is helpful to check initially so that we can determine what that top number might be close to, what might be close around to, and then we can then listen in for the sounds after we've done that. So essentially what you do, you put the blood pressure cuff on, you're checking the patient's pulse, you inflate the blood pressure cuff until the point at which you can't feel the patient's pulse. So once you can't feel their radial pulse, you know that that point on the blood pressure reading is going to be the point to where you're going to inflate the cuff. You're actually going to go about 20 to 30 over so that you can make sure that you're catching the sounds that we're going to be looking for. Once you've deflated the cuff, slowly after that pulse has been cut off, you will start to catch the beats coming back once you've deflated the cuff. And so when you're deflating the cuff slowly, you can check when those beats come back, and that's going to give you that top number, the systolic blood pressure number that we would normally be looking for. So after you've determined that palpable systolic blood pressure, you're now going to place the diaphragm of the stethoscope over the brachial artery, and you're going to start listening for the sounds that go along with the blood pressure. Okay, so we found that palpable systolic blood pressure number. Let's say it's 130. Okay, so their pulse returned when you were deflating the cuff, and it was right around 130. So if it's 130, you're going to now inflate the cuff up on the meter reading up to about 160. Now, I don't have a picture specifically of the dial or the monitor of the systolic blood pressure. Are all of you relatively familiar of what that looks like as to on the blood pressure cuff? So it's cylindrical in nature. You're going to inflate as the dial moves up close to 160 if you've noticed that their systolic blood pressure is around 130. So as you get up to 160, then you're going to start deflating the cuff. And that's usually the piece that requires the most practice when you are checking a patient's blood pressure, is to not deflate the cuff too rapidly or too slowly. There's a little bit of an art to it, and it requires a little bit of technique. The goal is to try and reduce the cuff and the number that you're seeing. You're trying to reduce it by about 2 to 4 millimeters of mercury every second. So you're deflating the cuff slowly from that 160 number, and then you're starting to listen for different sounds. So ideally, once you get up to that 160 number, you're going to not hear any sounds. As you start to deflate the cuff, you are going to start hearing a pulse come back, and usually it's a bump bump sound, bump bump. And as that number as you deflate the cuff, though, you're going to start hearing the sounds. As the sounds come in, you're going to hear 2 clear repetitive sounds. That's going to be your systolic blood pressure number. That's what you're going to record as the top number for the patient's blood pressure. And then we'll move into phase 2 through 4. So phases 2 through 4 are a little bit tricky. You'll start to hear a pretty pronounced heartbeat sound in phase 1, but in this phase 2, the sounds are a little bit softer and longer. You're still going to hear the heartbeat, but it might feel a little bit more muffled. Same thing with phase 3 and phase 4. Now, we normally think of blood pressure being 120 over 80, so there's a gap of about 40 millimeters of mercury between the two numbers. That's not always the case for every single patient, but we might have some sort of idea that as you're deflating it, you're going to work your way from phase 2 to phase 4, probably somewhere between 40 and 80 millimeters of mercury for a specific patient. Everybody's a little bit different, but you're going to hear sounds fully through phase 2 through phase 4, whether they're muffled or not, until they disappear. Once those sounds actually disappear fully, you're not hearing any sorts of beats from the heart, that's where you're going to record the diastolic blood pressure. So that gives you your 2 numbers. When you hear the sounds initially on the deflation, it's going to be your systolic. When they disappear fully, it's going to be your diastolic number. This is a graphical representation of these sounds. So in phase 1, you're going to start hearing the blood pressure sounds come through, and they're going to be the most pronounced in those initial couple seconds. And then as you deflate the cuff, you're going to see in between that 120 to 90 range, there's going to be a little bit of dip in that sound. So that's where you're going to hear the heartbeat, but it's going to be a little bit more muffled. And then as you work your way towards phase 5, that's where the sounds are going to disappear from what you can actually hear. This phase 2 is what we call the oscillatory gap. So the reason we did the palpable systolic blood pressure at the beginning was that sometimes when you're inflating a blood pressure cuff and you're listening for the heartbeat, if it goes away, it actually could go away in phase 2 as you're inflating the cuff. And so if you started to deflate the cuff in this range, you actually miss the systolic blood pressure number on the front end. And so you're not going to actually hear the appropriate systolic blood pressure in phase 1. You're going to start deflating it between 110 and 100, which would be an issue. So that's why we recommend doing a palpable systolic blood pressure, especially for a patient that you maybe haven't seen in the past. Here's another example of a little bit more severe situation where a patient might have more of an isolated elevation in their systolic blood pressure. So you can see in phase 1, that's at the 180 mark for millimeters of mercury. you would get up to over 200 to elevate the blood pressure cuff to over 200 to get into phase 1. As you can see, the phase 2 here is even more pronounced. Again, if you didn't do the systolic blood pressure, the palpable systolic blood pressure, you might be at risk of deflating the cuff in phase 2 versus getting up into the phase 1 with the palpable systolic blood pressure. Any questions on how to monitor or how to think about the different sounds that you might be listening to with blood pressure checking? Okay. So once you have actually done the blood pressure for a first patient that is seen in the clinic or in the pharmacy, we normally recommend checking both arms and using the arm that is the most elevated as the recording for their blood pressure. The blood pressure cuffs are broken down on even numbers, and so we recommend reporting the number as the rounding upward to the closest 2 millimeters of mercury. So if you were to give an odd number, it'd be kind of tricky to actually catch or confidently say that you're finding their systolic or their diastolic at an odd number. So we recommend if you do feel like it was in between one of the notches to round up to the 2 millimeters of mercury. Now, if you're checking a patient's blood pressure with one of our automatic blood pressure cuffs, or if you have an automatic blood pressure cuff in your pharmacy, you might notice that they do report blood pressures with odd numbers at times. And so that's just the accuracy that can come with an automatic blood pressure versus what we could perceive manually. In addition, recording the position, was the patient sitting, standing, or lying down, and the cuff size that you use can be helpful, especially if you're going to see the patient back again and check their blood pressure again. It gives you a recording of what you might need to check their blood pressure again. For special situations, infants and children, normal monitoring for blood pressure starts about 3 years of age and older. There are infant and children blood pressure cuffs available to get an accurate reading. The same principles apply for applying a blood pressure cuff. Another one I'll touch on is maybe for patients who are pregnant or obese patients. Sometimes blood pressure cuffs can be difficult to place over the upper arm. If you can't get a blood pressure cuff that actually fits over the upper arm, you can use the forearm. Same technique and same blood pressure cuff in the forearm if needed. It's maybe not going to be as accurate, but it can give us a reading to go off of for patients who might not be able to have a cuff that fits over their upper arm. Patients with atrial fibrillation may be ones that are a little bit trickier to check their blood pressure because of their heart rhythm. One of the things we recommend with atrial fibrillation is to do at least 2, even 3 checks, so alternating arms and checking their blood pressure to make sure that you're getting an accurate value and averaging the 3 values that you get for that for a patient whose heart rhythm might be tricky to catch as you're listening in on it. A mechanical heart valve is something that can sometimes cause disturbances with blood pressure monitoring. It's not going to eliminate the crock-cough sounds that you can hear, but there is going to be a clicking sound as you're checking the patient's blood pressure, and so you need to distinguish between the clicking sound and the crock-cough sounds that you would hear during the time that you're checking their blood pressure. So oftentimes you might need to check 2 or 3 times for mechanical heart valves to make sure that you're getting an accurate reading. Patients with AV fistulas or shoulder surgeries, we would recommend checking their blood pressure on the opposite arm of where that actually occurred. And so those are just some of the special situations that we recommend thinking about for blood pressure monitoring. From an assessment perspective, normal blood pressure is less than or equal to 120/80. That's what we consider a normal blood pressure. Elevated is higher than 120/80. And usually we run into the diagnostic criteria of hypertension once a patient's blood pressure is consistently over 130/80. Normally, it requires 2 separate checks to be elevated over 130/80 to receive that diagnosis of hypertension, or as we know, high blood pressure. And then hypotension is a systolic blood pressure, so a top number that's less than 90 to 100 consistently, and a diastolic blood pressure less than 50 to 60. Most of the time for hypertension, a patient's going to feel symptomatic with these values as well. So symptomatic would mean feeling those symptoms of dizziness, possibly lightheadedness, possibly feeling uneasy or unstable on their feet. That might be a sign of hypotension, especially if it's occurring as well when they're standing up or sitting down quickly. So that covers our blood pressure monitoring. I've kind of asked along the way, but before we move into temperature monitoring, any questions? Yeah.
So the automated machine ones, would you say are just as accurate as doing it manually?
Yeah, so it's a good question. What we know is that they are required to be standardized, and before they ever reach a patient, they should be able to be accurate to a point. The gold standard is still manual blood pressure monitoring with a stethoscope with your manual blood pressure cuff. But in practice, we normally see automatic blood pressure cuffs being used and used as a diagnostic tool as well for treatment. So we do consider them accurate. The gold standard is still recommended as manual blood pressure checking if you're unsure. So I would say a little bit of a gray area, but for me as like somebody who would be working in the clinic and seeing our physicians treat off of it, they consider an automatic blood pressure cuff accurate to the point of recommending treatment. Now, we will normally also, if their blood pressure is elevated, we will normally double check what their blood pressure was 5-10 minutes after they got their first check with an automatic cuff as well, just to make sure that there wasn't any false elevation or any inaccuracies with it. So, yeah, good question.
What about those wrist ones? Are they just as accurate as the normal ones?
So the wrist ones are not as accurate. Yeah, the wrist ones are not as accurate. Yep, and that's a good clarification. So the wrist blood pressure cuffs can maybe give you a range or an idea, but they're not as accurate as one that's going to go over your brachial artery. Yeah, great question.
And for those, you just use the radial pulse instead?
For forearm, you do use radial pulse still. Yep. So you get it up, try and get it up as much on their forearm as possible, and you can still check the radial pulse. Yeah, great question. Other questions? Okay, great. So I'd say that's probably the most significant section that we have here. We'll move on to temperature. So monitoring temperature, there's many different routes and ways that we can interpret temperature. Of the 4 here that we have listed, we also can check it via the forehead as well. And I think there's a slide that's in here to monitor that. One of the key clarification points for temperature too is that fever diagnostics and how you monitor temperature is going to differ for infants and children. So for an infant or child that is less than 3 months in age, the normal recommended way to monitor a temperature is either via the armpit or axillary to get an idea of if they're even running a fever to start off with. And if they are running a fever, then you can check it rectally. After 3 months, in the 3 to 4 month period, really all of these start to play in, can start to be used. The tympanic membrane, so within the ear temperature, is going to be recommended after 6 months of age. And then oral temperature is usually after 4 years of age. So we'll kind of cover those here. Different types of thermometers available. The nice part of these digital thermometers is that they're relatively cheap for patients to pick up too. Some of these can get pretty expensive. Even especially if you're looking for like an in the ear thermometer, sometimes they can be cost prohibitive for some patients, but Digital thermometer is usually pretty affordable. Again, these are going to be used more for your axillary, so you're under the armpit blood pressure, thermometer, as well as your rectal thermometers as well. The things that we kind of look at or pay attention to for these for patients, I think I mentioned, is over the age of 4. If you're checking an oral temperature, making sure that you get the monitor down into the side underneath their tongue and holding it there, usually for about 10 seconds. So that goes for oral thermometers, that goes for rectal thermometers, or under the armpit. It usually should give you a reading at about 10 seconds. Now, I don't know if any of you have used these recently, but sometimes it takes a little bit longer than 10 seconds as well. So trying to get a child to sit for a longer period of time, I know can be a challenge. So in that 10, 20, 30-second range, it should give you a reading. Hopefully that's consistent with a number that would make sense. So tympanic membrane thermometers or in the ear thermometers. So as you can see here, the thermometer or the sensor is going to be inserted into the tympanic membrane or the external auditory canal. It's going to be getting the temperature that's radiating off of your tympanic membrane, which is your eardrum here. And so these thermometers can be accurate. Again, we want to be careful of using these in the ear thermometers until after about 6 months of age, just because of the development of ears. But they can be an effective way to check a patient's temperature. And then we have temporal artery thermometers. So these are the ones that are going to be checking your temperature on your foreheads. Now, you've probably also seen with COVID, we have forehead thermometers that don't even require you to check a temperature while rubbing it across a patient's forehead. You can hold it about an inch away and kind of shoot a temperature gun at a patient's forehead. You've probably seen that either at an airport or at an event during COVID or right after COVID or the peak of COVID occurred. I shouldn't say that it's necessarily over, but those are your temporal artery thermometers, and that's running across your temporal artery. It's checking the temperature that's running off of that. So as an example of how that would look, there's different directions for different products, but oftentimes it requires moving it from one side of the forehead to the other and holding down a button while you're checking the temperature for a patient. Again, the ones that are off the skin just require kind of clicking a button and making sure that you're close enough to the temporal artery to get the temperature. When we think about temperature from an assessment perspective, these are the numbers that are considered normal versus fever. Now you'll notice, depending on the way that you're monitoring their temperature, there's going to be different metrics for what a fever would be. So normal is normally around 98 to 98.6 Fahrenheit. A fever is 100.4 if measured rectally, 99.5 if measured orally, and greater than 99 if measured via the armpit. And normally the recommendation is if you have measured a patient's temperature via the armpit, that you usually recheck it with something else. And that especially applies for our pediatric children. So if you've checked their temperature via the armpit and it's above 99, you might want to check it rectally to make sure that they're actually running a fever. Oftentimes, the reason we recommend that is if a child just got out of the bath or out of the shower, or if they were swaddled up, that can falsely elevate the temperature. But from a rectal perspective, that's going to stay a little bit more consistent. That's kind of where you can run into some of those false positives or false negatives. Same thing for adults, like if a patient just got done exercising and you check their temperature using a forehead thermometer, you might notice that you're going to get a falsely elevated temperature. It doesn't necessarily mean that they're running a fever. The things that we get a little bit more concerned about is this greater than 105 degree Fahrenheit. If you were to start seeing numbers greater than 104 or 105, that's really a referral threshold where they should probably be further evaluated in an urgent care or possibly an ED. Any questions on temperature? Are these products being used or bought? Are you seeing these being bought at the pharmacy pretty consistently, especially in the COVID world? What would you say are the most common ones that you're seeing being purchased? Is it usually the classic digital ones or the oral? Yep. Okay. Got it. Great. So the final piece here is the pulse oximetry. So pulse oximetry measures the oxygen saturation of arterial blood. So essentially, it's monitoring our hemoglobin carrying oxygen molecules throughout our body. Hemoglobin can carry up to 4 oxygen molecules per hemoglobin molecule, essentially. So if you have 100 hemoglobin molecules carrying up to 400 oxygen molecules, if they're carrying only 380, then that's 95% of the capacity. So that's kind of where the calculation is occurring and what is actually being tracked. A value of 95% to 99% is normal. Usually less than 90% needs medical attention. And so oftentimes we'll see patients at risk of a lower pulse ox or oxygen saturation for patients who maybe have COPD or a long-standing history of COPD. So that's lung disease that has maybe occurred from smoking or other environmental behaviors, or possibly a patient with long-standing asthma that's not well controlled, or any sort of maybe infection like pneumonia. Oftentimes pulse oximeters are going to be used to track those types of disease states and make sure that a patient's oxygen saturation is staying where it needs to be. I know that most pharmacies carry pulse oxes. Is that true for the pharmacies that you work at as well? Okay, great. So that's another way that we can check pulse ox. The color of the blood varies depending on the amount of oxygen. Really, essentially how it works or how it's actually checking the saturation is it uses 2 beams of light through the finger. You can also use the earlobe. Usually the finger's a little bit easier for patients and a little bit less painful. But these beams determine the color of the blood, and then that leads to a calculation that spits out the number for their oxygen saturation. For most patients, it requires a strong pulse. If they have very cold hands, they might not get an accurate reading, so they might need to warm their hands up, run their hands through hot water, if that's a possibility to warm them up. For some patients, they just can't get their hands warm enough to give an accurate reading or to give any reading at all. Larger fingers or smaller fingers can also kind of cause disruption with these 2 beams. You want to try and make sure that the pulse ox is lying flush on a patient's finger. However, for a patient who has a very large finger or a very small finger, sometimes it's difficult for it to be flush against the skin. A patient who has had carbon monoxide poisoning is going to have a false elevation in their pulse oximetry reading. Skin pigmentation shouldn't typically affect a pulse ox. It possibly may overestimate it if a patient's pulse ox is less than 80%, which is usually pretty rare unless something's really going poorly. So those are just a couple different things to think about from a pulse ox perspective. That takes us to the end of this presentation. What questions can I answer kind of as a final consideration?
Okay, so,
Yeah.
with the pulse ox, have you found that patients with atrial fibrillation don't always get an accurate count?
Yeah, I hadn't heard on the atrial fibrillation side. Is that something that you've noticed? Okay, yeah. That's not something that I've necessarily heard specifically, but it could lead to the strong pulse or the pulse that's getting far enough into your finger pulse. Yeah.